The broadcast is now starting. All attendees are in listen-only mode.
All right. Hello, everybody. Thank you for coming to this webinar training. I'm going to give folks a couple of minutes to hop on before we get started, so feel free to use the restroom or do whatever you need to do before we get going. If you do have any questions or are having issues tech-wise, please feel free to jot down those 2 emails and send any questions, concerns, etc. along. All right, let's go ahead and get started. Again, welcome all for attending today for our New Pathways, Brief and Effective Interventions for Addressing Chronic Pain webinar training with Dr. Ashley Greenwell here. Just want to give a couple of points for you all before we officially get going. My name is Alejandra Del Toro, and I am the project coordinator with Empower Idaho. For those of you that are attending your first Empower Idaho event, just wanted to let you know we offer provider trainings and education and advocacy for adults with behavioral health conditions in Idaho. In our control panel overview here for the program we are using, want to note that every audience member is muted. So if you have any questions or comments, please utilize the questions drop-down box and input those throughout the session. We will be answering those to the best of our ability throughout the presentation, but we'll also have some time towards the end to get those questions as well. Under the handouts drop-down, there is a copy of the slides in PDF format if you'd like to follow along. And then a big portion of this, as far as the CEUs, I have a couple of reminders. In order for you to receive the CEU, we do ask that you attend the entire session. Please have registered with the email address that we will be sending that out to, and that'll be towards the end of next week. And the name that you utilized when registering will be that name that we will put on the certificate. So if there are any changes to that, please send an email to either of those email addresses, and we can definitely make sure the correct certificate gets sent to you. Again, that can be, you can expect that towards the end of next week. Lastly, if you are watching as a group with coworkers, please email us a list of the names from your boss of all of those that are attending so we can confirm and get those certificates out to you. So if there aren't any other questions, we'll go ahead and turn the time over to you, Dr. Greenwell. Thanks again for joining us today.
Wonderful. I'm assuming everyone can hear me okay. All right, let me know if otherwise. Well, welcome everyone. I first just want to say thank you for spending your lunch with me. I feel like many of us have so much on our plate right now with school starting and life as it has been. So I hope this is a pretty informative and helpful talk for you on a really, really, I think, complex but important issue. In terms of my background, so I'm a psychologist by training, and I've been practicing for about 15 years and actually started doing all trauma all the time, right? And that both physical and psychological trauma. And the longer I've been in this career, the more I realize how body-based interventions are key, right? So we know when someone lives with chronic unresolved trauma or stress long enough, it shows up in the body, right? Some of you may have read that huge book by Bessel van der Kolk called The Body Keeps the Score. In terms of what I'll be doing today, clearly some people spend their whole lives studying chronic pain. This is going to be an overview, but my hope is that you leave here with a pretty good sense of the latest thinking around addressing chronic pain, as well as some very concrete practical strategies. And I'll leave some time for questions at the end. So again, like I mentioned, chronic stress and how it resides in the body has been my background. I'll also say, personally speaking, you know, many of us as we get older, and when I began getting into my 40s, there's just a certain amount of discomfort that goes with being human. And we'll spend some time talking about how we relate with that, right? All right. And I bring that up specifically speaking, you know, at any given time, and I imagine many of the attendees could say the same thing. My body is giving me probably somewhere between, on a pain level, 2 to 7 of discomfort in my neck and jaw, right? And I encourage you to kind of think through your own lenses of your own experiences with pain as we go through some of these strategies. All right, so let's see if I can, there we go. So again, today, the relevance is probably pretty clear, but we'll briefly talk about that. We'll talk about the latest science theory, controversies, and updates. We'll zoom into specific strategies for intervention in the room. And also, hopefully there'll be some time for questions in the end. All right. So let me start in the most basic place, which is 1 year ago, the definition of pain was revised and changed. And there's an important shift that was recognized in this new definition where they added the words resembling with that associated with. And so let me read the whole definition. But pain used to be defined as an unpleasant sensation and emotional experience associated with actual or potential tissue damage, or described in terms of that damage. And so you see these little extra words that are put in here. An unpleasant sensory and emotional experience associated with or resembling that associated with. Now, even me reading it, it's a little bit clunky, right? But what they were attempting to communicate was the idea that pain is a complex, contextually based experience, right? And what do we mean by that? If you were to think of the last time you were in serious physical pain, I'll give you a moment to kind of call that to mind. The way that you experience that pain in the context, including your internal beliefs and values and understanding and predictions, as well as your external situation and cultural norms and perceived health, profoundly influences the experience, right? For example, I'm out of Salt Lake City, and I would say there's like a tattoo shop on every 3 blocks now. The pain that someone experiences when getting a tattoo is very different from the jaw pain that might wake me up at night, right? The meaning making changes. And that gives us a window of what we might want to do to help people. Okay? The other kind of issues that might come up is around pain expression, right? What is culturally normative and acceptable? So, as many of us know, chronic pain is pervasive. It's the leading reason adults seek medical treatment in the United States. And when you look at figures, it's almost 1/3 of people report some degree of chronic pain. About 1 in 5 report daily pain. But I want to start by just giving you an overview of what is out there. So when you look at the most common types of chronic pain interventions, you can scan this list, and I bet many of us either have been part of providing these services or receive them ourselves. And what I want to point out here is that quote at the bottom, and this is by Dr. Harris, a neuroscientist at the University of Michigan's Chronic Pain and Fatigue Research Center. He basically says, our treatments are very bad. Now, this is a striking comment, and this is a comment from 1 year ago. And what he means by saying this is that the quality of evidence for actually reducing the perception of chronic pain is not good, right? That the majority of people, after they engage in these treatments, and we'll talk more specifically in a moment, do not report that their pain has meaningfully reduced. So again, that poses a problem, right? And when we get at some of the therapies that we'll talk about, some of them, while they may not reduce the actual perception of pain, what they do reduce is the impairment and the perceived burdensomeness, right? So someone at the end of some of these treatments might say, I still sense it, but it doesn't interfere or cloud my whole experience the way it used to. And then at the end, we'll talk about some new interventions that are truly aimed at reducing the pain sensation. You know, there could be a whole talk on the waves of opioid deaths and overdoses, and that's its own separate thing. I do want to acknowledge it and the suffering it's caused in many communities, including especially Idaho and Utah. So there's a clear urgency to find new interventions. They say 3 waves because you notice the different types of opioids that became more accessible, and more recently fentanyl posing a serious risk. Now, I won't talk about treating kind of opioid use today. Safe to say that reduction of opioid use does come with certain risks, right? So we know that risk of suicide increases and exacerbation of other mental health issues. So it's not something that should be taken lightly. I want to jump into a little bit of theory here. And, you know, for some of you, this may be really obvious, but this is something, an example that I'll use with patients that I work with. So why is someone coming to see a psychologist? To zoom way out for our body, we have almost 100 billion neurons inside us. And some of them can fire up to 200 times a second. And I can't do the math on that, but suffice it to say, there is a huge quantity of sensory data that our poor brains are attempting to process and prioritize, right? Getting so much information. And our brains have something called the Salience Network, which helps us figure out what can I ignore and what can I zoom in on for survival, right? Now, pain is an adaptation that's your brain's opinion on how to protect yourself, right? You know, the old idea around pain was that it's just this robotic automatic response. What we know is pain is a construction, not always consciously or intentionally, but a construction that our brain is forming around threat. So let me give you an example. Let's say you are hiking outdoors on a trail, and you happen to see this creature to the left, right? This mountain lion. And you start running. I don't think you're supposed to do that, but let's just say we're scared and we're running. And you roll your ankle. Now feel free to guess here in the chat, but how do you think your body will process the pain of your rolled ankle when there is a mountain lion behind you chasing you? We'll pause for a minute, and someone who's feeling brave can throw in their guess. All right, I'll give it one more second, but then I'll jump in, assuming you are you're eating. Okay, so many of you can guess you're not going to perceive the rolled ankle in a way that is distracting. But if we flip that, let's say instead you're really hungry and you've decided to go hunting and you're chasing a deer. Oh, good. Yep, I see some answers. You won't feel it. That's right, Angie. And Amy. Now, let's say you're chasing a deer because you're hungry and you want some food. And you do roll your ankle, similar way. Now, what's going to happen is quite different. The likelihood that you're going to feel the pain in your ankle is much higher. Now, why is that? It's the exact same injury, but your brain has formed a different meaning about it, right? And in one case, better to stop running and to find another deer as opposed to with the mountain lion, right? And there's so many examples throughout history of this when you see soldiers on the battlefield not experiencing pain, or conversely, you can have people in a virtual reality kind of like a experience where they have the perception of being rear-ended in a car. Their neck doesn't actually move, but you'll have a significant proportion of people who report whiplash after, right? There's another classic example with a man who was doing construction and put a nail gun and it went through the toe of his boot. And he's screaming and crying and saying how much pain he is in the hospital. They pulled the boot off and missed his toe. Now, he's not making up the perception of pain. It was his brain's estimation to protect him, right? To inhibit him from ignoring this issue. So let me see if I can get to my next thing. So really briefly, we won't talk too much about this, but what we're learning in more recent years is that there's different types of pain. The one that we're most acquainted with is nociceptive. And the nociceptive pain is just tissue damage. You slam your hand on a car door and the nerve fibers fire, you feel the pain. And we also knew a lot, and you probably see a lot of patients with neuropathic pain, where there's some kind of damage to the nerve fiber, right? Where perhaps you're not being injured outwardly, and yet the nerves are firing. But this nociplastic pain that shows up in things like fibromyalgia and irritable bowel is different. This is pain that arises from an error in your body's pain detection and processing system. So basically, we have these neurocircuits, and then we have amplifiers and inhibitors that turn the volume of the pain up and down. And so these amplifiers are taking sometimes seemingly normal, typically normal sensations, like I'm brushing my hair, or I've got a little discomfort in my stomach, or I'm digesting my food, and amplifying it and turning it into a painful experience. And oftentimes, it may start with one type of pain and then evolve into another. So I work a lot with people who have gastrointestinal chronic issues. And if you were to imagine traveling, right? You go to another country, you try something on a food cart, you get on the plane and you realize, oh no, to get back home. Your stomach becomes very upset. So there's a lot of research that says, an initial kind of physical insult like a virus, coupled with a highly stressful circumstance, primes your nervous system. Let's say you're sitting on that plane thinking, oh no, where's the bathroom? Oh no. To then be hypersensitive in the future, hyperreactive. It changes your pain processing system. And, I use the word hypervigilance, or sometimes you'll hear people talk about PTSD of the body when describing these pain syndromes to clients. And personally, I think that's much more effective than using the word anxiety, right? Of you're getting anxious, your body's too anxious, you're getting anxious about your pain, which can be pretty invalidating. Now, I won't go into the biopsychal spiritual complex of pain. But suffice it to say, pain is incredibly complicated. And I think when this collides with our rushed, brief patient experience, where you have a few minutes to address a lot of problems, it creates quite a tension. The tension between, oh my gosh, I have to get this done quickly. Perhaps the patient wants a simple solution. And then you look at all these factors that can influence the perception of pain. Right? Some that are social problems, right? Not quickly solvable. We also know that there's some vulnerability factors, even starting at a young age, for pain experience, and that can set people up to be more likely to have chronic pain. You know, the saying is, when you can't say no, your body eventually will, right? That this inflammatory stress response, when we're exposed to adverse childhood events, can put things in motion. There's also some personality traits here listed that contribute to constant stress and inflaming the body. So alexithymia is described as difficulty being able to register and interpret one's own emotions. And so you can imagine, if you're not sure what's going on in your body, it might be channeled into describing it or understanding it as physical pain. All right. Now, so there are some things that can kick pain into gear and cause that initial pain, but we know the way that patients respond to physical pain, although it's natural, can set them up for more problems. So you can imagine, if pain leads to fear thoughts about what's happening to them, more anxiety and avoidance, disuse and disability, then they're more likely to experience pain, right? They can become deconditioned over time. And this is the rationale for why cognitive behavioral therapy is used. And we'll talk more about that. I won't spend too much time here, but I think many of us who ourselves as patients or as providers are in the hospital system understand that navigating it is incredibly complex, right? Whether it's in-network, out-of-network insurances, pre-authorization, it's very hard. And I bring this up because oftentimes the people we see with chronic pain, they're very seasoned, skeptical patients. They've been through the roller coaster already of hope, maybe this will help, and then disappointment. To a point where there can be some learned helplessness, right? And there's some really, I think, important tools we can talk about in terms of how do you get off that roller coaster where you're not the next person who will save them, but also you do have something, or cure them, but you do have something to offer. All right, so the interventions we're going to talk about, whether you grab a cognitive behavioral therapy book for pain, or an acceptance and commitment therapy book for pain, or a self-management book, they do have certain components that they include in different ratios. To some extent, they're all going to try to help the patient understand pain, much in the way that I described, right? That you do have a dial that you can turn the volume up and down on. In terms of relaxation training, this is a tough one to introduce, but that is an important component if their body is in a chronically stressed, tense state from the pain. How can they begin to unwind that? Pacing we'll spend some time talking about, as well as cognitive coping and increasing pleasant events. But it's not so much the what, it's really the how, right? How does this get presented in a way that can be digested and used? Before I do jump into some specifics around the pain, though, in the interventions, I do want to say that oftentimes when a behavioral health individual is coming on board, it needs to be after there's been careful screening for organic causes, right? I remember an example where I was listening to a talk, and he was a gastroenterologist, and he had a patient come in who said, oh my gosh, I've had so much trouble swallowing and I have this lump in my throat. And the gastroenterologist said, well, when did it start? And he said, you know, a few days, maybe a week after my father died. And so his first line of thinking, of course, is, okay, well, we do know that stress can increase the likelihood of globus, right? That sensation, or of functional GI disorders. They thought, you know what, we better get imaging. So he referred him, and it turned out he did have the beginnings of esophageal cancer. So again, that's, you know, my clear disclaimer here. You're always going to want to make sure that you're either connected to or communicating regularly with the medical team. Right. All right, so let's zoom in. And what I'm not doing today is giving you kind of a full overview of CBT or ACT, kind of the main or pacing main self-management interventions. What I'll be doing is talking about some key pivotal interventions in each of them that you can take with you. If you are interested in learning more kind of a particular modality front to back, let me know and I can recommend some books, and there's some others in the resource section. All right. But in general, what we are doing with chronic pain, right? So pain that that's been evaluated and found to be caused by the amplifiers in our body, we're helping them downregulate their attention to pain, their hypervigilance, and then the behaviors that result from it, right? So reducing that threat signal. All right, so let me start with the assessment piece. And if you have time and energy, there's some really lovely formalized assessments that can be used. I will tell you, to be honest, it is more rare that I use them. If you're like me, oftentimes time is quite limited. There's a number of presenting issues you're trying to get at. But just so you know they're out there, there's a pain stage of change coping questionnaire. And this is a questionnaire that really gets at how does the individual relate with their pain. So an example of an item on there is asking them if they agree with the statement. Why can't someone just do something and take all my pain away? Right? Another statement on there is, all of this talk about how to cope better is such a waste of time. So really seeing what they view as their internal role and agency in addressing the pain and what they want to be done to them externally, a solution provided to them. There's also a pain catastrophizing scale, and I'll show that on the next slide, that gets at how distressed are they about their pain? What additional layer of upset do they put on that their body is generating this sensation? Something that I like to ask people that's a bit more informal and acceptance and commitment therapy technique is, if your pain were personified and knocked on your front door, what would they look like and act like? And how would you feel about them being there? What would you do? Okay. Scaling pain is, you know, that the rating that many of us see in hospitals, right? Pretty subjective. Here's the pain catastrophizing scale by Sullivan, and that's just available online. Okay. But you can see with the items, people who are reporting this way of thinking a lot of the time may really benefit from some cognitive approaches, right? That their beliefs about their pain are turning the volume up. So controversies. Is pain-free possible for chronic pain? Well, when you look in the Cleveland Clinic online on their website, they very clearly say there's no cure for chronic pain, right? On the other side of things, Curable is an app that I happen to really like, but they do market their name Curable, that you can be cured, you can be relieved from chronic pain. My personal experience in working with individuals who have lived with chronic pain for some time is I tend to focus less on removing all symptoms and much more on you can find a life that grows bigger and feels more meaningful such that the pain feels smaller, but not searching for cures. And, you know, there's something called the 6 F's to chronic pain. And that has to do with when your client is doing these things, it is dramatically turning the volume up on the pain. So those F's are, I have them on a future slide, let's hope I remember them. One is fearing the pain. One is trying to figure out the pain. And I've had clients come in with spreadsheets and spreadsheets. On this day, I ate this and I did this for exercise. On this day, a lot of distress. Trying to fix the pain, right? Looking at pain-free. So let's see, fearing, fixing, fighting the pain, trying to struggle with it, right? So these ways, they all kind of lump into psychologically trying to undo it. One question I get a lot is, should we target the pain now? Right? And oftentimes you'll have people come in who have a range of issues that are going on for them. These are red flags, and all these slides are in the handouts, like Alejandra mentioned. If they're actively suicidal, if there is another mental health issue that is more pressing, then maybe the pain gets put to the side. Certainly because, as we discussed, some of these things fuel each other, you can do concurrent treatment. And then, I don't know how often each of you get these, but sometimes when people come in and it's just the pain, everything else is going well, and that's a given, that's an easy one. Right? So the place that I like to start with clients is setting expectations. I do that in 2 ways. One, I start by saying we're not trying to make all of the pain go away, right? And that is probably their goal, is to remove that rain cloud of pain. Instead, we are trying to build a life outside of the pain, a life where things matter, where the pain is not overshadowing all. Right? And I do think sometimes when you say this to someone, there is a bit of grief around that. And there can be this process of creative hopelessness where you are the bearer of pretty bad news. But creative hopelessness coming from the place of, now that they've given up on trying to eliminate it, perhaps they can put their energy and investment into something different. I also do spend some time talking about amplifiers and reducers, right? And again, those 6 F's, fearing, focusing on the pain, being frustrated by the pain, fighting the pain. All of these things will turn the volume up, increases our threat response. The other type of phrasing I'll use to people is the difference between hurtful and harmful. Once they've been evaluated by a medical professional and they found that there's not structural damage, if engaging in daily routine behaviors, right, like cleaning, moving magazines, or brushing your hair, or brushing your teeth, or standing, are causing pain, we help them figure out the difference and the labeling that something, it might be hurtful, but it's not harmful, right? And that can be as simple as when my jaw pain, right, starts triggering, reminding myself, we're okay. I'm talking to my body in the we, but I'm okay. There's not damage being done. I'm getting a pain sensation. It's unpleasant, but I'm not being hurt by it. Now, I want to jump into first starting with the old but good strategies. And these are the things that we all know are good for reducing inflammation and improving our overall health. But the patients have been really inoculated against them because they've heard a lot of quick prescriptive advice, right? Like, oh, you got to work on your sleep. You should eat healthier, right? You should take more breaks. And the first thing that I will bring up is, while that is incredibly important, and sleep is incredibly important, as is nutrition, if you don't have time to implement behavioral interventions to improve those behaviors and follow through and check on them, I would say don't do it, right? Many of us have probably, attempted to improve someone's sleep quality or attempted to examine their nutrition. And if they've heard it enough times, they don't want to hear it, right? Another thing I do when I'm introducing these types of strategies around promoting general health behaviors that we all know are important is I get willingness and buy-in at the very beginning. So I tell them at the very beginning, I can't do anything is off the table, right? So that place that someone might be sitting where they're on the couch and they're thinking, I should walk around the block or I should go sit outside. I'm trying to teach practice where they're learning in that moment when their pain or their fatigue is saying, no, I just can't do it, is off the table. Now, I'm not saying they have to walk around the block, but what I want them to practice is some new different behavior, right? And as providers, I think we need that window and their permission at the beginning to be able to run these experiments, right? These low pressure practice assignments where it's okay if you fail, it's okay if you didn't walk around the block, it's okay if you stayed up on your phone for 3 hours instead of trying to go to sleep when you had intended to. But we're also going to talk about it. We're going to talk about it from a kind of curious, compassionate way. And I think that that can be hard. One, when time is rushed, but two, many people experience a shame response, right? You're not wanting to sit across from someone and say, okay, you said you were going to practice this. Why didn't you do it? And instead, we're coming from a place of, let's learn. What did you learn about this experience? What should we try out this next time? Right? And they may experience shame, but you can count on the fact if they're feeling judged in the room that that's showing up for them somewhere else in their life. And to avoid it or to simply give a new, different type of assignment on a new issue is jumping it around in a way that's often not productive. I'm happy to share this. This is a willingness and action plan that I really loved from acceptance and commitment therapy. And it links small behavioral goals to what they really care about, right? It also says, okay, we know if it would have felt pleasant and fun and easy, you would have already done it. So what thoughts and memories, feelings, sensations, and urges are you willing to have be present when you do this thing? What are you going to remind yourself of when it gets tough? And then checking in on that. For CBT, one thing that I think is incredibly important is making sure you get granular enough, right? It's easy to talk broadly speaking that thoughts can be unhelpful or thoughts can be barriers, or that we can have too much of an alarm response when pain shows up. But what I found to be much more effective when I'm doing CBT is to really make it very specific. So I'll give an example. If I have a client, there's a lot of research that says a certain level of exercise when a person has cancer can actually reduce pain, right? Now you can imagine if a person has cancer, it's very easy to say, oh my gosh, stay on the couch. And so a woman I was working with, not just did we do these global interventions, but I had her sit and close her eyes and imagine being on that couch and imagine the discomfort in her body, right? And in that moment, when we say dragging out the new behavior, having her imagine something different, like what she might get out of it, right? And that can be used in terms of motivating behavior, but can also be used on the opposite side. When someone's about to pick up a drink they feel like they shouldn't have, right? You might have them close their eyes and imagine what they might be thinking in that moment, which could be something like, I just want to feel better. I just want to relax. I'm so sick of this. I'll start quitting my drinking tomorrow. And instead, having them rehearse in their mind what they would like to consider. Like, if I have this drink in the morning, how am I going to feel? Or if I have these 5 drinks. So again, getting their perspective memory to consider what they want to consider in the moment. The other thing I like for CBT is actually practicing the behavior. Many people with chronic pain, there's this cycle of guilt and feeling like they are having to disappoint others frequently. Perhaps when they're feeling good, they make commitments. When they're feeling bad, that they have bailed on people. And when that guilt accumulates, or perhaps they never felt comfortable doing this, being able to very clearly have the scripts to explain what they can and can't do. And what I found is it's one thing to talk about the need to be assertive and set limits. It's another thing to actually do it in session. And for almost all of my clients, we're sitting there and doing it, right, in the moment, where I'm saying, all right, I need you to disappoint me. How did that feel? How did that go? And that dramatically increases the likelihood that they'd be able to do it in real life, right? So pacing, many of you have probably heard about this for chronic pain. And almost like a phone battery that wears down over time, what we know is that there is a boom and bust cycle to pacing. And what that means is when people feel good and have energy and their body feels okay, they work as much as they can. And then they crash and have to recover. And then the laundry builds up, and then the voicemails build up. And then they feel good and they rally and try to get caught up. So you can imagine that this doesn't work because it's sort of unsustainable or feels chaotic. But another reason it doesn't work is that we know when people overextend over their limits, the time it takes for them to rest and recover becomes increasingly long. So they become less productive. And I like to present this directly to the clients and say, this is why that strategy is going to get worse and worse over time for you. Right? So along those lines, well, let me see. I'll check my notes and see if there's anything else important I wanted to make sure I zoomed in on there. Okay, so for that adaptive pacing, what this is basically a process where you help the patient become intentionally engaged in an activity. And when their pain increases on their own internal scale by a certain amount, you have them practice taking a break. And then you measure how long of a break does it take for their pain to go back down. And in general, attempting them to keep them in the zone where they can more sustainably be productive without requiring rest days where they feel non-functional. So there is a reason that people get stuck in this boom and bust pattern. And the environmental contingencies can fuel that. So you can imagine most of us, we stop working or we stop some kind of productive task. We like to, at least, because it's done. Now with chronic pain, we have to really unpack and undo this. Figuring out whether or not you stop or take a break can no longer be just determined by external cues of, is everybody else taking a break? Did we finish the project? Do I feel completed? But instead, noticing what your body's asking for. Okay? And some of that might be exploring their judgments about taking a break, exploring their skills about letting people know, I just can't do that. Or if I go with you, I'm going to need a chair that I can sit in because I won't be able to stand up for that long. Okay? And you'll work with some people that will very readily be able to identify their somatic cues in their body, and other people where you'll really, for example, you'll pick an activity. Maybe you'll be walking with them and you'll help them notice. All right, where's your pain now? How about now? How would you tell me, or how would you decide to stop? What kind of thoughts in your mind show up when you consider doing that? So it can become a very real experiential process. All right. Jump to the next one. Okay, so mindfulness interventions. Mindfulness has become pretty pervasive, and there's mindfulness-based stress reduction, there's acceptance and commitment therapy, there's hypnosis, there's yoga, and many of them, there's many different kind of brands to pick from, but at the end of the day, what you're helping the client do is deliteralize their thoughts, feelings, and emotions. And you can see why this is powerful for pain if they've learned to experience pain as a threat and as dangerous. Being able to have those intense sensations without perceiving the harm is pretty powerful. Being able to have the thought, I'm a failure or I can't be productive the way other people are, and not take it literally and not act from it is important. And there's a few different metaphors that people will use. ACT, for example, uses passengers on the bus, right? This idea that you can't control who gets on and off your bus. There's going to be some passengers you love, passengers you don't like, all of them giving commentary as you drive your bus. And despite their, whether they're dominant or nice or pleading or convincing, ultimately you get to drive the bus. IFS will do something similar with your parts, right? That's internal family systems, where you're sort of exploring your mental tribe and compassionately understanding the different parts of you that show up. But when you look at the research, one thing I will say is when it comes to pain reduction, the improvement is going to be primarily in the reported quality of life and the psychological symptoms. People are not reporting huge reductions in their pain directly. So another thing, and this has been around for a while, is relaxation interventions, right? Diaphragmatic breathing. The question is, and the challenge is how do you get people to do this, right? I mean, most people in the mental health field work with clients who say, just please do not talk to me about breathing, right? They've heard it. But I think that the introduction is incredibly important. One thing I explain to patients is that with the amount of stress and discomfort and distress your body's under, it's an essential, right? What we know is that as we age, without intervention and lifestyle changes, the pain is not going to get better on its own and likely will get worse. And so I'll spend a lot of time talking to people of if we have to get in a dosage of deep relaxation at some point in your day, where we put it. I do like to bring neuroscience in. I like to talk about the gas and brake pedal in your body, what helps and what hurts in terms of efficiency of your parasympathetic nervous system. And then I have them practice it at least once with me in the room, right? All right. The last piece, and this is really driven by behavioral activation, acceptance, and commitment therapy, is if I'm wanting to connect with my client in a deeper way, besides just trying to get rid of pain, I want to really understand, if no one were judging them, how would they want to walk this planet? With the time you have, who do you want to be? And that can really drive creative ways to address their values. So I have an example of a tattoo here, because I was speaking with a client who's developed severe rheumatoid arthritis that has really changed the structure of his hands. And that's caused sort of a loss of control. It's caused some shame and embarrassment. And we were really saying, like, well, this will not be undone, right? Now what? What matters to you, right? And I said, well, I'd like to be able to look down at my hands and feel good about them. And for him, that meant he got a tattoo that was really meaningful to him. And that did a few things. One, it was consistent with his values. And two, it just simply kind of gave him a distractor to look at and remind him. All right, so I want to jump into new interventions in a moment and give a little bit of time for questions. But in terms of key strategies, one of the things that we can do that's powerful is removing the in your head versus medical issue debate. Their pain is real and it's not their fault. So that is a statement that I think, if you do nothing else, putting it out there for them is powerful. I also, with all of my clients, like I mentioned, will introduce false alarms and hypervigilance. We need to provide a compelling rationale for them to do these behaviors that they've been described or prescribed repeatedly, but are hard to follow through on. We need to be able to wade in and get granular. Right? The other thing I certainly tell people is functioning will improve before symptoms, whether that's their anxiety or that's their depression or that's their pain, that they will be able to do more before they feel better. So there have been some cool new areas of study. Virtual reality for pain management has grown dramatically, and that's used for chronic pain, but also post-surgical pain now. And it's become much more cost-effective. So you have a number of insurance companies now covering it and putting client costs down to things like $30 a month. This is an example of a virtual reality program where there's an individual who had severe neck pain when turning his neck. And what he found is when he's doing this scuba program on the virtual reality screen where he's swimming with dolphins, he can turn his neck. And basically he's training his brain like this motor motion does not have to bring threat. It does not have to bring danger, right? There has been some initial research on psychedelic-assisted therapy for managing pain. That is in its very much infancy, and of course, there's a lot of legislative issues there. Another area of study is neuromodulation and brain stimulation. There's been some promising research coming out there. And then a new line of work around quantitative sensory testing. So like I mentioned, there's a different types of pain. And instead of when someone's coming in and saying, I'm in pain, now take a pain pill, right now take an NSAID or a opioid, really diving in and understanding what exactly type of pain is that. And they're getting some better diagnostic testing to then match the treatment. And there's the source there where you can read a lot more about it. So in summary, living with chronic pain is dealing with daily challenges around simple tasks that most people can take for granted. I think invalidation and stigmatization is the norm. And it's important that we help people understand that they don't necessarily have an ongoing injury and they don't necessarily have to stop what they're doing. And lastly, patients need to be believed, respected, and supported, right? But we do not have perfect treatments. We do not have treatments that cure the pain for chronic pain. So that's a sense of sort of humility and compassion that we have to bring into the room. All right, I think we have about 5 minutes for questions. Here is my contact information. Feel free to email me if you would like access to the handout on the Willingness and Action Plan. And otherwise, I will open it up to see if there's any questions.
All right, and then just so everyone has a little bit of instructions for asking questions, you can just type in the questions drop down if you want us to unmute you, or if you just want to type out the question, whatever your preference is. But yeah, we'll be taking questions through that way. I guess meanwhile, those filter through. Again, CEU reminders. Thank you everybody for attending the full session. We will be emailing those certificates out to you. Everything that you inputted with registration as far as the email and name goes, that is where we will be sending along that certificate and the names that will be included. Looks like we have a question that came through. Will you offer more training? Great info. So just out of curiosity, Catherine, are you referring to from Dr. Greenwell herself or different Empower Idaho trainings? And then Dr. Greenwell, it looks like there was another question that came through. If you want to go ahead and answer that. It goes, I just started working with a preteen with a genetic condition that causes frequent bone breaks. She says she tries not to focus / tune into the pain. What general approach would you take?
So my first thought that comes to mind, Amy, and I suspect you might be doing this, is that there is likely a lot of grief there, right? I mean, when we talk about preteens, you're going into that developmental period where there's a tremendous amount of comparison. And so just in some ways feeling alienated and their own sense of identity, I think is pretty important. But when we get specific to the pain, this is a quick answer, but oftentimes I'll ask them how they do with relaxation training. Do they like guided imagery? Do they like yoga? Do they like breathing? If so, then I'll get them set up with recordings and we'll begin to monitor that. But I have some people that just do not like that, right? And in that case, I'll much more often take the cognitive route, right, where we will keep it more concrete and specific. The other thing is, you know, Amy, when she says she tries not to focus or tune into the pain, I find myself sometimes asking some really specific questions. What do you mean by focusing on it? What do you mean by tuning in? Because what I want to understand is we also don't want, there's a middle path in there between allowing the pain to be present while still living your life, but we don't want someone who is frantically avoiding it. And so sometimes, as a little example, I'll turn my cell phone alarm on my phone during a session, right? And it's just ringing. And that's pretty aversive, right? It's pretty negative. And what we're talking about is there would be a way for us to turn and be so annoyed with my phone. And there would be a way for us to run out of the room, perhaps. But again, can you be with that discomfort in a compassionate way? So that's my quick answer there. In terms of Catherine's question, will there be more trainings? There's a lot of areas in health psychology I'm pretty passionate about. Disorders of gut-brain interaction, I think, are pretty important. That's another area I speak on. And I can talk with Alejandra either through her program or perhaps I do some online webinars as well. So feel free to check out my website. I can put updates there. What initial approach would you best recommend for end-of-life pain? Oh, okay, that is such a huge question. I think it's its own talk there. I mean, when we talk, to me, what first comes to mind is sort of the ethical and legislative issues there. When we think about medical aid in dying and pain management and palliative care. But I will say the quick answer is I most often will use acceptance and commitment therapy. And the metaphor I'm using in my mind with pain at the end of life is a steady rock. Like I'm imagining I need to be able to be rooted so that they can feel safe enough to be authentic and real and feel cared about. That's the quick answer to a very important issue, though. Good question. All right.
So it looks like we've reached the 1 hour mark. If there are any unanswered questions, Dr. Greenwell has her email listed right here. You're more than welcome to reach out to her. I just included a couple of links if you'd like to sign up for our newsletter and take a look at our upcoming webinars that we have this fall. There's quite a few provider trainings that offer CEUs that are coming up in October, so be on the lookout for that. Otherwise, thank you for attending and hope to see you in future events. Thank you, Dr. Greenwell.
Take care, all of you, and email me if I didn't get to your question. Take care. Handouts are online. I did see that question.
Oh, yes, perfect.
Under the handout section of GoToMeeting.
Yes, thank you. Thank you so much for that. All right, have a great rest of your day.